So now we go to retroperitoneal vessel injury. That should be probably the most traumatic ever. It's if you ever experience it, the early recognition is the key to patient survival. Do up and down laparotomy, grab the aorta underneath the renal arteries, get IV fluid. If you see hematoma, do not open that hematoma because it compresses, and then call the vascular surgeon if you need them. So this is a very old film that I showed at the AGL meeting in New York in '94 or something. And we violated every principle of surgery. We did not have, this was a young lady with pelvic pain. We did not have scissors, so we decided to do with the unipolar needle. The resident at the time, she was moving like she's got Parkinson's disease, and she hit the iliac vein with the monopolar needle. So we freaked out, and we basically, at that time, I didn't even know how to suture laparoscopically. We plugged it off with the blunt probe, and miraculously the bleeding stopped. We watched the patient, it was Dr. Wolf and myself, we watched the patient, and this huge hematoma has formed. But then she became stable and it did not grow. So we took her to the PACU and she was fine. We did the MRI, the CT, you can see the huge hematoma, psoas muscle here. So we got away from it. With it, I do not recommend you ever try this. So the aortal perforation, as I said before, it happens when you put the patient in intrainguinal position, and then you're gonna nail it. So here again, we are in a surgery center outside the hospital, and I did tubal ligation, and after the tubal ligation, you always check, or at least I checked the abdominal cavity, and then I see this mass behind the uterus, right there, retroperitoneally. And first thing is I think, oh, maybe she has pelvic kidney. Then I look further in the gutters, and I see blood in the gutters. I turned to anesthesia. I said, what is her blood pressure? He said, I can't measure her blood pressure. The blood cuff doesn't work. So then then I saw this here and I froze. I realized I've hit the aorta and this is like retroperitoneal hematoma. And so what was going on through my head at that moment? So the first thing is obvious normal reaction, and then I thought, let's withdraw the trocar and pretend nothing happened. And well, in that case, she's dead, and my career is dead also. And then I got vasovagal reaction that I felt that somebody hit me with the trocar and aorta, and then I became very religious. But that didn't help either. So I realized we need to call vascular surgeons. We transported her to the hospital. She survived, and I did survive. And then I talked to everybody. I couldn't comprehend how did it happen. It's just like if you do your first curettages or whatever, and you perforate the uterus, you swear to God that somebody perforated before you, right? When you're putting those agards, it's just like it's the same thing. So I just talked to everybody, and they said, well, it happened to this guy, whatever. Within the 6 months in the Louisville area, there were 4 cases. So these things happen, but nobody talks about it. And there was an unfortunate girl across the river in Indiana that was operated by a general surgeon for a 2-centimeter ovarian cyst, and he hit aorta and then opened her up and then brought her to Louisville, and unfortunately she died. And so those things happen, and then you would say, why didn't you do a Hassan technique? So this film is not mine. It was given to me by a colleague in Europe, and they did Hassan technique on a very thin patient, the country of Norway. So when they went with the 11 blade on a thin patient, they cut the aorta with the 11 blade. So no technique is idiot proof in general. So you have to be careful and, you know, pay attention to every patient individually. So they tried, they looked at it, they even tried to put the bipolar on it, but eventually they realized they have to open up the patient. They did, she survived. Then you could say, well, if I do robotic surgery, this is not the true. This is not my film either. So this is a, I guess, assistant putting a robotic instruments in, and with the scissors hitting, same thing, aorta. So what's interesting on this film, you can see how long it takes the surgeon to leave the console and whatever, scrub in and open up the patient, and how quickly they pull out the camera out of the patient to basically do laparotomy, obviously. One thing that they should have done is they should have clamped the aorta with the robotic instruments to minimize the blood loss while they were waiting. So here is a very old video. I was teaching attending in private practice how to do hysterectomies, and this is before harmonics, before ACE of harmonic. This is old harmonic, and obviously this guy was not really a very good surgeon, and was thinking, well, he was trying to control the uterine artery, and I'm taking the camera. This is unedited video. As I put the camera back, the blood goes into my camera, and every time I get like Japanese flag. And then finally I clean the camera against the bowel instead of taking it out, and I go in and clamp the artery. I don't care if I get the ureter here or not. It's a temporary pressure that will allow me to clean everything, first of all, to get a breather, and then be able to complete this surgery. So I, not by desire, just by kind of coincidence, I did the largest laparoscopic hysterectomy in the world recently, 2019, on 7.4 kilo uterus. And this is part of that uterus that you can't see the liver, absolutely. So it's uterus all over the place. And I swear to God, this is my fellow, she's great. And I told her to cut here, and you can see the amount of blood you can get in a very short time. We lost, I think, like 300 cc's there in a very, very short time, because it's like a fire hydrant. And so the key is here, I'm controlling the suction here, and whenever I press on suction, there is no, the blood stops, and then she coagulates from her side. And I'm telling her, Megan, go lateral. Blood supply comes from lateral, and then we were able generally to control this and take the whole uterus out. The entire blood loss was 400 cc's. And here I do a lot of endometriosis surgery. Basically, that's what I specialize in. And in this case, we did resection. We did the left urethral lysis. And the process of the resection of endo, we got into the uterine artery here. And it's not really a big deal. You can coagulate the uterine artery on a patient that is nulliparous, because there is collateral circulation to the uterus. So we tried the first thing is you try to put the gauze, and then you try the gauze, then we put the snow, which didn't even work again. And then we finally coagulated the artery and got the control of the bleeding.